So, good afternoon, everybody. I'm going to proceed. Thank you very much to the organizing committee for the invitation to be here and to share something on the considerations in patients with FD-MAS, but from an oral and maxillofacial perspective. So I'll introduce myself very briefly because I think most of you don't know me. My name is Sarina Pichardo and I'm an oral and maxillofacial surgeon and I've been for almost 10 years now. I used to work in the Leiden University Medical Center where I worked in very close collaboration with Natasha and with Stijn. And 2 years ago I transferred to another university hospital in the northern part of the Netherlands, in Groningen. And with my bone expertise, I take care and I coordinate the clinical care pathways and still in a very close conjunction with the Leiden University Medical Center. So I have a special interest for bone and bone tissue, and I do a lot of bone surgeries as well. And I did my PhD thesis on osteonecrosis of the jaws, so I'm going to tell you a little bit about it too in this presentation. So you're all familiar with what fibrous dysplasia is. It's a bone disease where normal bone and marrow are replaced with fibrous tissue, what leads to weakened, brittle bone. We see it more often in the upper jaw than in the lower jaw. And there are three forms: monostotic, polystotic, and craniofacial. And if we look at the distribution of the lesions, we see that 45% are located in the craniofacial region. So what symptoms do the patient present with? Well, most patients with monostotic lesions present at a later age. And if you look here on the left, you see a lady with a swelling of the lower jaw on the right. You see that it's more prominent than on the left side. And if we look at the two pictures here on the right side, we see here a woman from above, and you can see the swelling of the cheekbone here on the right side. And this is the intraoral view, so it's from below where you can see the swelling. This is another patient, also with a swelling of the cheekbone, now on the left side. And this is the corresponding intraoral view, where you can see the teeth, and you can see that the jaw has expanded in horizontal dimension. But you can imagine that if it grows vertically, that you can get disturbances in the bite. Like, for example, in this patient, you can see that there's a lesion here in the lower jaw on the right side. And you can see that an open bite is developing on the other side because this lesion is growing. You can also see that there's not enough room for all the teeth. You can see that this teeth is sort of being pushed out. And if we look at the right photo, which is the same patient, but a few years later, you can see that the tooth actually was pushed out, so it has been removed. You can also see that the bite has become deeper, and the lesion has grown. But I will get deeper into this case later. So the diagnostics, what are the diagnostics that we use as oral and maxillofacial surgeons? Well, in the first place, mostly when we see patients that present for the first time, we make a panoramic radiograph. And I assume if you all go regularly to the dentist, you've all had a panoramic radiograph because it's an X-ray that immediately gives an overview in 2 dimensions. Then you can make a CT or a cone beam CT. I think most oral and maxillofacial practices have a cone beam CT. That's a small CT that only scans the head, and it's a 3D scan as well. So you can see the lesion in 3 dimensions. Afterwards, you can make a bone scan. We've heard about it, sodium fluoride PET scan or other kinds of scintigrams to measure the bone activity and to see if there are other lesions. We do the blood work to assess the bone metabolism and, in case of growth, also hormonal evaluation. If the diagnosis isn't clear on radiology, You have to take a biopsy for histopathological analysis and to look for the GNAS mutation. So this is a panoramic radiograph, and you can see, you get an immediate overview of the upper jaw and the lower jaw. This patient has a lesion here on the right side. This is her right side, by the way, because this is left, and this is right for the patient. And this is the normal side. If you look at the normal side, you see the teeth in the upper jaw and the teeth in the lower jaw, and you see here the canal that runs through the lower jaw. That's the mandibular canal, and through the canal runs the inferior alveolar nerve, and it comes out here, and it provides the sensation of your lower lip. But if you look at the other side, you see an irregular aspect of the bone with dense spots and with less dense spots. But if you try to look and follow the canal, you can hardly see it. So the bone has changed. This patient also has a fibrous dysplasia lesion in the maxilla and also in the cheekbone. And here below we see the corresponding scintigram, where you can see an increased uptake in the lower jaw and in the maxilla, and well, it runs up to the skull. There are still countries that make anterior-posterior X-rays. In the Netherlands, we don't make them very often anymore, but it can be very helpful. This is an anterior-posterior X-ray. These are where the eyes are situated. This is the nose, and here's the upper jaw and the lower jaw. You see the teeth here. And this is the unaffected side. This is the maxillary sinus, which is supposed to be filled with air. So it looks black on the X-ray, and it does. So this is the healthy side. And you see here that it's not black. It has all kinds of shades of gray. So that gives you the idea that there's something there. It has also a little bit of irregular aspect, and maybe here in the lower jaw it also looks very irregular. So I would advise to make a CT or a cone beam CT. So here on the right we see a dental film. Most dentists make these kinds of images. Here we see the teeth, which are in the bone, and the teeth are aligned with a very thin black line. There are the fibers that keep the tooth fixed to the bone, the so-called periodontal ligament. And if we look here at the aspect of the bone, we see here a dense structure. So also on dental films we can sometimes see the beginning of fibrous dysplasia lesions. So this is the case of a patient with a lesion in the upper jaw on the left side here. This is a horizontal plane view of a scan. And we see the normal side here on the right. I think it's at the level of the roots, net just below the nose. And you see here that the jaw has expanded very widely. You see the aspect of the bone is also very irregular, with a little bit more dense and less dense areas. Here on the right, we see the 3D reconstruction of the scan. This is actually how it looks like below the skin, where you can see the swelling. So these are pictures of the corresponding sodium fluoride PET scan, where you see a very increased uptake in the upper jaw, in the frontal view, and also in the transversal view. So let's talk about treatment. If the patient doesn't have any complaints, I don't see why we should treat. And I think we can all agree on that. But if there are complaints, if there are functional problems, if there are bite disturbances, if people develop traumatic deep bites, so that means that the bite is so deep that you start chewing on your gums, which can cause all sorts of problems, or if there are seriously aesthetic complaints that may lead to psychological problems. If you see signs of progressive growth, or the idea that there's a polystotic disease, you have to refer, of course, to the endocrinology. And then the treatment could be either conservative with bone strengthening therapy, or you can perform a surgery, which is always partial and comprises of shaving or contouring, and preferably a combination of these two in consultation with the Department of Endocrinology. You can see it, but I wrote it in very fine print. There's never an indication for resection and reconstruction, so full resection of the lesion, because sometimes you find these pictures in literature with very severe cases of fibrodysplasia lesions, and then you have surgeons that think that you can remove everything and then just plan a 3D implant, but this is just not an option, in my opinion. These major surgeries lead to mutilating situations, and of course, everybody can understand that you can damage vital structures such as nerves, maybe even the brain and blood vessels. So what can we do when we're talking about surgical treatment? Well, we can just recontour, the shape of in this case, for example, the upper jaw or the lower jaw. So here we see 2 scans before and after surgery, and this is the view of the upper jaw now again below the nose, and you can very clearly see that there's a lesion here on the left side of the patient, and you can also imagine the excess. So what we do is that we make a planning. Before all the 3D technology that we had, we used to do it just in our heads or on paper, and then you would just measure the excess. And I think the excess here is 5 to 7 millimeters. Then you can do the surgery and then you can remove it. And then if you're lucky, it looks like this afterwards, and you have removed and you have recontoured the shape of the maxilla in this case. If we look at the more newer techniques that are available right now, you can also perform the surgery while you have real-time feedback. And the technology that we use for this is actually nothing more than just an advanced version of a Nintendo Wii. I think a lot of people have these in their homes. You have a receiver, that's the thing that you have on top of your television. You need a screen so you can actually see what you're doing. You need a patient and you need a pointer, that's like a GPS. And in advance, you make a planning. So you have a scan of your patient with the lesion, and what you do is you mirror the unaffected side, so the healthy side, to the affected side where the lesion is, and then you get an idea of what your excess is and what you need to remove. And you can use the scanning and the superimposing of the scan and your planning during the surgery. And then this is, for example, a patient that we did. He had a lesion in his cheekbone on the left side, and these are 2 scans that are. This is the mirroring that is superimposed, and what you can see, the red is the mirrored side, so that's the right side mirrored to the left side, and it's especially visible here in the upper view. There's an excess of almost a centimeter, I think, in projection of the cheekbone in this patient. So if we perform the surgery, this is how it looks like. That's me. And I'm holding the pointer. And then you can see where you are and whether you have reached your planning or not, or you have to remove a little bit more. So this is the post-operative scan. I haven't superimposed them, but I think you can see that we were able to remove some of the excess. In literature, I found another case where they performed it. There's a lady here with a lesion on the cheekbone of the right, and this is post-operatively, where you can see that the symmetry has been restored. Now I'd like to show you the case that I already discussed for a part. It is a 43-year-old lady, and she had a lesion in her mandible on the right side. And she was already, I think, 15 years that she was followed in our department, and we didn't do anything except for giving her some bisphosphonates to try to decrease the activity of the lesion. I already discussed with you that the teeth were moving and that her bite was changing. And one day the woman came again, and she was sick of her bite disturbances. She had a visible swelling of her lower jaw, and when she would speak, you would see her gums, which is unnaturally. And she asked us to consider performing a surgery. So we did. We made a planning. And she had an increased height of the lower jaw. So what we did, again, is that we mirrored the healthy side to the unhealthy side. And this would be the new height of the lower jaw on that side. But that would also mean that we would have to remove all these teeth and leaving her with no teeth in that area. So what we did was we made a cutting guide so that we would make sure that we would only remove this part of the jaw. And then we also made a drill guide for her dental implants so that we could place the implants so later the implants could be restored with crowns and bridges. So this was the post-operative scan that we made. You can see the implants are here, and we have diminished the height of the mandible. And we also did a recontouring. That's what you can see here, because the lesion had also expanded in horizontal dimensions. So the results, they were really great, I think. She was really happy. This is her smile. And what I really like about this case is how dynamic bone tissue is, and the capacity of the body to restore normal function again. Because we removed this lesion that was actively growing, and after we've removed it, we saw that the tilt here in the occlusal plane, it had shifted because of the growth of this part. This part of the upper jaw, these teeth came down again. So she has a more or less normal bite plane again after surgery. So concluding, fibrous dysplasia of the jaw is not a fully treatable disease, as full removal is not possible. We always strive to as a conservative treatment as possible with bone strengthening therapy and/or limited surgery to treat functional limitations. Well, of course, without multidisciplinary collaboration, even international good treatment isn't possible. And surgical treatment is only recommended, I think, in expertise centers. Now, as an oral and maxillofacial surgeon, I get a lot of questions from patients, from parents, from dental practitioners. Well, what about orthodontics? Is it possible in patients with FD? What about corrective jaw surgery? And what about osteonecrosis of the jaws when bisphosphonates or denosumab are used? Well, I'll try to give a brief answer to these questions. But let's start at the beginning with the question on orthodontics. And to explain that, I'm very, very briefly going to explain the physiology of the orthodontic movement of teeth. And it may look a little bit complicated, but it's actually very easy. The tooth is fixed with these red stripes. Those are the fibers, the periodontal ligament that I already mentioned. It's fixed in the tooth socket, in the bone. And if you place a bracket and you put an orthodontic force to it and you push the tooth towards the front, What happens is that the fibers here at the front compress, and that compression leads to activation of the osteoclasts. And you know the osteoclasts are the cells that resorb the bone. So the osteoclasts will resorb the first layer of bone cells. And at the backside, the orthodontic force leads to a pull force at the back. And that pull force, that leads to activation of the osteoblasts. So those are the cells that build. So they build one line of cells at the back. So very slowly, the tooth moves through the jaw. And if you understand this principle, you understand that orthodontic treatment in fibrodysplasia is possible. And literature confirms it. The only thing you need to be aware of is that the orthodontic treatment may take longer, depending on how dense the lesion is. It's recommendable to avoid the use of mini screws. Those are tiny screws that can be used for the orthodontic treatment. I think it's wise to avoid any surgical procedure in lesions to prevent it from growing. Patients with fibrodysplasia sometimes also have oligodontia. That means that they miss teeth. They can have problems with the development of teeth, so they can be hypomineralized. There can be rotations of teeth, so that's a malpositioning of the teeth. They can have bite disturbances. So I think regular follow-up at the dentist or orthodontist is very important. And if necessary, of course, in consultation with a surgeon. And corrective jaw surgery is possible, and complication rate is not necessarily increased. So what if you need to start with the bone strengthening therapy, bisphosphonates or denosumab? Now, as you all know, this medication is responsible for inhibition of the osteoclast activity. It will decrease the bone resorption, and this will lead to an increased bone density. Now, there are several forms, oral and intravenously denosumab, and depending on the indication, you have a certain administration manner. So if you have to start, now what? Let me start by saying that the chances for osteonecrosis for fibrodysplasia patients is very small. The numbers that we have are 0.5 to 7%, but those are for osteoporotic or cancer patients. We don't have numbers on patients with fibrodysplasia of osteonecrosis in fibrodysplasia patients. But considering the fact that the osteonecrosis doesn't develop spontaneously, but it is always related to dental pathology, the advice is to resolve all dental problems, preferably before initiation of therapy. Low-risk patients, those are the patients who have an intravenous use for less than 1 year. They do not necessarily need to use antibiotics for procedures as removal of teeth at the surgeon or at the dentist. All patients who have a longer use or use denosumab, they do need to use antibiotics in any procedure and should be treated preferably at the surgeon. Well, is a drug holiday necessary when using bone strengthening therapy to prevent osteonecrosis? A drug holiday, so that means the temporary cessation of the therapy, it's not effective for acute situations. So if you need to have a tooth removed, just do the tooth removal, because the halfway time of the drugs is way longer. If it's possible, try to plan halfway between the administration, or at least 2 months before the next administration, so the bone has enough time to recover. However, if you are going to do elective procedures, plannable procedures, such as implantology or orthodontics or even corrective jaw surgery, you could consider stopping the medication for a short amount of time. And also, of course, in consultation with the prescribing physician. If we look in the literature tells us that this was a study that they did on mice, that with the use of risedronic acid, which is also bisphosphonate, that the delay of tooth movement can go up to 50%. So you need to take into account that your treatment really takes longer if you have used bisphosphonates. Well, there's a decrease in number of osteoclasts, and there's less relapse. Relapse, that's the tendency of the teeth to go back to their original position. So that's actually a good thing. And you need to take into account that you should not put too much force on the teeth to move through the jaw, because that could lead to damage to the root, and what you get is what you see here. This is before the orthodontic treatment, and this is after that you get shortening of the roots because of the pressure. So I would advise to go to someone who has a little bit expertise with or all the patients that use bisphosphonates or with patients with bisphosphonates. Well, if you do these kinds of treatments, I would recommend a drug holiday. Your relapse is decreased, and also surgery is possible under the right circumstances, of course. So now really concluding, fibrous dysplasia of the jaws is not a fully treatable disease. Orthodontic therapy or corrective jaw surgery or with the use of bone strengthening therapy is possible, but I would advise consultation in expertise centers. Chances for osteonecrosis of the jaws are small, and surgical treatment could be indicated but only recommended in expertise centers. And of course, brush your teeth twice a day and go to the dentist on a regular basis. Thank you for your attention.